Kita akan pakai pointer macam ni. Maksudnya anything yang ada tunjuk-tunjuk untuk ditunjuk macam ni. Tanpa dekat sini dia akan keluar. Dekat tak, dia akan keluar ni tu. Maksudnya bila dah tunjuk kat sini, at the same time online pun akan nampak yang sama. Kalau tak ada tunjuk tu, yang ni nampak tapi online tak nampak.
Betul je cara nak buat macam ni.
Okay tak? Thank you tu.
Cuma mouse je lah.
Mouse je. Cuma nanti untuk next slide tekan bawah. Bakis, share slide tu slide yang kedua kan? Yang YouTube tu.
Kan kena
So it's like the bila sampai step tu, boleh terus masuk untuk menceritakan. Dan just forward, dia dah akan continue. Sehingga ketemu apa cakap sampai kalau kau boleh, kau tidak steering kan. Ya. Buat sini dah, sir.
Kalau tadi lain lain stable.
Masukin dulu. Mas. Silakan maju.
Yang bahagia Ketua Pengarah, Datuk-Datuk, Tuan-Tuan, Puan-Puan, I am Major Dr. Shanas from 21 Squadron Medic DGK. I will present the initial part until the patient was brought to 94 heart. Mention of overview that things happened at 16:35. Patient was alleged by tree trunk, followed by 16:40. Patient was arrived at 21 Squadron Medic area. Subsequently, we noticed this patient need transfer at 16:55 and we sent this patient with ambulance at 17:05. So this is what happened on that day. At 16:35, patient was standing nearby watching his friend chopping the tree. When the tree trunk was cut into half, it became unsteady. Due to that, the trunk snapped and swung onto the patient that's standing nearby. So this arrow actually shows the site of the incident, and this is the Squadron Medic GDK where the patient get his first treatment. So patient was brought in by colleague by walking, noted that he was alert, conscious and in pain. He was attended stat by the paramedic at 21 Squadron Medic. The case was informed by the paramedic to the medical officer, who is me Dato, and attended stat. The vital sign was stable, the BP was normotensive, the pulse rate was normal, no tachycardia, temperature at febrile, respiratory is 18, SpO2 is 99%, the pain score was 4/10, however increased during mobilization of the left shoulder, and I done the primary as followed. So this is the condition of the patient when was brought to the 21 Squadron Medic. I done the primary survey for the patient. The airway is patent, the breathing is normal, the chest rise equally, no chest rise asymmetry, no tracheal deviation, no respiratory distress, the breathing sounds present. The circulation, no severe circulation. D, disability, patient was conscious, GCS was full, and for E, exposure, I noted there is a left shoulder deformity. Looking, the patient was stable. I proceed straight away with the secondary survey. On examination, GCS was full, 15/15. The patient was oriented to time and place. The lungs was clear, equal at entry. No cardiovascular finding as noted. The per-abdomen soft, no guarding and non-tender. There is a laceration wound, 3 cm over the left forehead and 4 cm at the right cheek. And there is also a multiple abrasion wounds seen over the chest and neck. My primary diagnosis at that particular time was left shoulder dislocation and multiple laceration and abrasion wounds. So this is the treatment that I gave at the Squadron Medic. I gave him Emborin 50 mg stat and also ATT 0.5 ml stat, and I proceed with the toilet and suturing over the laceration wounds. During the TNS, noted the SpO2 monitoring was fluctuating and dropped to 92%. He was then immediately put on nasal prong 3 liter per minute and the SpO2 picked up to 100%. So new vital sign was taken again. The BP was normal, normotensive, the pulse is normal 18, not tachycardic, respiratory is 18 and SpO2 is 100% under the nasal prong. However, the lungs mark reduced breath sounds over the left side of the lung, predominantly over the left lower zone and the middle zone. The CVS S1, S2 normal, per abdomen soft, no guiding and non-tender. My impression at this time is left pulmonary injury and left shoulder dislocation. and noted that the patient's condition is dropping, I straight away referred this case to Lieutenant Colonel Dr. Muzamil, ED physician of 94 Heart, and informed this case to the MOED on call as well, Major Dr. Shuhada. Then patient was sent by our ambulance to 94 Heart at 17:05.
Can you check back all the first picture? Left shoulder dislocation. Tapi mobility kat belah left shoulder. And then nampak macam ada dislocation, nampak dislocation di komputer tak ada. Macam presiden model dapat. I don't know how we can get that. Macamnya you can disability. Disability ini, I don't know, bukan conscious disability. Disability ini is more you think that ada future that can see you sometimes that or tapi bisa dah tak ada tu so that seems to be right. We can go when you not that not taken good condition. Since Dr. Muhammad cakap saya itu juga kan pulse oximeter kan. So bila kita ada injury proximal katakan kat shoulder atau ada vascular compromise, so dia pulse oximeter itu disebut organ design. Bila dia ada dropping itu kan atau circulation compromise, so that to be injury. Okay. So kalau you boleh relate dengan batang pokok yang dia tertimpa kan, tapi you can imagine what sort of or what extent of injury yang this patient will get. Okay. So because kalau tengok tadi model the time baru nanti kita tengok the changes kan. So kalau kita boleh relate, then you can really visualize what happened, especially after injury. This is where kita kena lebih alert. Kita buat apa tu, so-called survey itu yang menjelaskan kalau sekali tengok macam ni, kita tengok batang pokok yang sebenarnya kita tempat berdekat dengan pokok tu kan, boleh tengok macam mana all can ask really what happened. And then we can really say really apa yang kedua, I was like tengok dia punya ni the vital sign tadi. Kita tengok itu pasti itu rasa normal lah. Nah, so dia orang ni dekat komando tau, kan? So masa aku jadi M4 dulu, dia punya baseline passage 40 itu 46. So this is where bila kita kata siapa nak join komando apa semua tu, what we want for you when you duduk dekat komando is for you to see what is your baseline. Tidak boleh equalkan dengan orang lain because of the high input training to the baseline passage more or less 60. So kalau dia orang kalau 82 ni dah almost aktif dia lah. So itu salah satu telltale. Saya kata bila you pergi kat sini, you work with them, you have to see then only you can relate. Sebab bila saya tengok gambar dia apa tu ada lajak biru, I had experience before. Because as I said, I was in the 32 komando. So kalau kat 32 komando tu, kalau kau ikut buku medical dia SPP, hari-hari kita kena information untuk medical dia. Sebab itulah baseline coverage orang 50. Sebenarnya dia tu relate yang kau belajar 80 normal. This is where kita tengok relate dengan penis ataupun person dan kita tengok this level. This is yang satu lagi yang enak kita faham, especially those yang posted to the special unit. We just have special training, we are very special. That's one of it. Because saya lihat sekali lalu kan, training dengan teknikal dia, experience. So benda-benda macam ni yang kita tengok lah, supaya kita tak generalizekan semua benda sama. And especially kalau tengok patient macam tu, and kalau punya index of suspicion is still low, then it's very very challenging lah. Sepatutnya kita tak boleh nak kita ikut pula. Refer is something I tengok punya timeline tu, siapa ambil time apa tu, ambil masa terus benda ni laku, who took the time. Kalau tengok the timeline tadi depan,
daripada information ambulans gerak pukul berapa, and also daripada history taking Datuk. Daripada history taking patient bawa sampai kat resat 60-40 documentation kat resat.
Dalam 15 minit dia dah molek. Yang kedua, if you have enough time for your proper assess the patient. Seperti yang 10 minit ke apa tu bersedak, kita tahu lah. Ini daripada mana sudah udang kan? Terus udang ke bersedak, kita 10 minit. Lagi. So itulah kata kita kena buat satu benda. Kita seek this kind of profession tau. We seek result as a profession. Bukan nak tengok sequence 5 minit, 10 minit, 15 minit, 20 minit. That is ideal. Itu apa? Tanya siapa yang pegang jam, yang ambil apa masa ni? Siapa ni?
Orang tengok jam juga dah tu. So documentation 7005 daripada ambulance punya dokumen. Lepas tu referred case to specialist from my phone itself, saya call Datuk Dr. Muzamil. And arrive kat skadron medik daripada documentation yang patient datang, my paramedik ada catat pukul berapa. And alleged hit yang 1635 tu daripada history taking. So diorang datang baru jadi doktor 5 minutes ago. Dia cakap baru jadi terus angkat ke resat.
So jadinya 052
Daripada tempat saya ke 94.
okay what you do, but the timeline is macam. Well, I'm happy if that's going to be that fast. Okay. Tapi dalam hal ini, we are not talking about the time, but we can put time spent properly. It's not the same time, sebab apa? Kalau you rush when you're primary surgery, that's what happened in the hospital. Jadi sebab kira, you be your second chance. So, kalau you dah dulu masa hospitalization, there's no such thing. The straight way, itu saja. Ada apa-apa. Kalau you tengok dari segi how patient progress very fast. Jangan be that fast. Bayangkan dalam masa 50 kalau tu 40 minit tau. Kalau kata orang sekolah medik, refer to specialist, kalau ada window period of 5 minutes. Dalam 5 minutes, repeater daripada normal, SpO2 normal, develop to cardiac and also acute. So do you think that's how it works? Kalau that's how it works, maknanya you fail on your primary survey. Maknanya you expect for benda-benda tu tak. You didn't put your expectation that this kind of injury will go to that. Dan you nampak pada only the shoulder dislocation. But we forget, for the shoulder to dislocate, bukan kembali dengan bantal tau. Kalau kembali dengan bantal, shoulder ada roller. The thing shoulder will dislocate. For shoulder dislocate, contohnya you need a high impact. So that is where your index of suspicious is not for just the shoulder dislocation. What are other injuries yang can cause by this kind of heavy object, high impact to the shoulder? What are other organs? What are other bones that there at the journey? But bila macam tu, bila that kind of analysis, only then you come up to the expected result. You tahu kat situ the vital organ is numb and the shoulder is dislocated. So we have clavicle there, we have ribcage there. So these are the things that we should have in mind. Bukan yang go for the obvious. So okay, tengok shoulder, that's it. So not so obvious yang kita kena tengok. So this is yang saya nampak. That's what happened kalau kita primary care. Then for me, my obvious word is that don't rush when you are in a hurry. Okay, so tentukan benda tu proper supaya bila sampai hospital they have a better diagnosis. Most importantly, the patient are stabilized properly. But I'm not sure dalam ambulans tu orang pakai apa. Ada PED ke? So because it's not about rushing to the hospital, but to prevent further injuries in transit. Daripada your squadron to number 4 hospital. Apa yang boleh berlaku kalau until unless you are aware of the type of injury, then you're not going to protect them. Dan sekurang-kurangnya mental skill tidak can stabilize the patient. Kalau berapa sebagai tahu yang patient ni there will be multiple injuries, bukan shoulder dislocation. Okay.
Thank you very much, Dr. Shanas. As the case continue, it's good to refresh back about the previous presentation. These are the case chronology that we presented on that day itself. At about the 16:55, we received a call by Major Dr. Shanas. It was a brief history about the one soldier was hit by the tree trunk, was brought by 21 Squadron Medic by his colleague. The initial assessment noted to have the obvious injury at the left, only over the left shoulder at that moment. Apart from that, slight laceration wound over the left forehead, which they were doing the toilet and suturing. Then noted the SpO2 was dropped at that moment. He was later put on nasoprong oxygen, and the case was planned to transfer immediately to Hospital Terendah. And at this moment, the documentation that we have, not the documentation, by the CCTV recorded, the patient arrived in emergency department around 17:20 hours. He was triaged to the red zone as the first history noted by the referring team suggests that it is a high impact injury. At the first vital reading as followed, the blood pressure was 125/70 with a pulse rate of 75 and the oxygenation SpO2 100% under nasoprong oxygen. And the rapid trauma survey was performed immediately subsequently after that. And for this rapid trauma survey finding for the case presentation, there are three parts that we would like to highlight about the significant positive finding, which at the anterior chest where the patient is having the skin crepitus and reduced breath sound over the left lung. And as well as over the chest posterior part, there was a tenderness over the left upper ribs posteriorly. And as we expose the patient with the extremity, there is obvious deformity over the left shoulder. And followed with the adjunct of the rapid trauma survey, the diagnostic was given immediately. And we add on with the imaging procedure, what we call the EFAS. And I would like to discuss a little bit in detail about the EFAS in a subsequent slide. And the case was proceed with the CT imaging after discussed with radiologists with the activation of the CT trauma protocol. And for what we call the EFAS, or in the long word mentioned, is an extended focus assessment of sonography in trauma. Yes, sir. Yes, sir. Emergency department. Yeah.
There was the advice repeating, not repeating. So
extended focus assessment of sonography in trauma, what we call EFAS, previously known as a FAS, or what we call the focus assessment sonography in trauma. The initial FAS is only covered for the 4 areas, which are what we call the right upper quadrant, the left upper quadrant, the pelvis or suprapubic view, and the subcostal or subxiphoid to look into the cardiac view. And for the extended component, it was added with the right thorax and the left thorax. And looking into the findings, something to share about how do we see the finding in a normal versus the abnormal. As the picture showed in this image, on the left side it is normal finding of the ultrasound or focus assessment sonography EFAS over the right upper quadrant area, where we can see the diaphragm and there is a liver, followed by artifact of the lung window on the above part. However, on the other pictures show that above the diaphragm, there was an obvious hypoechoic collection, or what we call the dark colored collection, with the lungs appeared collapsed. And how do we know about this finding? Is looking into the posterior part of it that having the vertebra finding. So these are the indicators to say that the patient is having the pleural fluid. But not for this patient, it's just that for the discussion. And the next part of it, when we do the right thorax and the left thorax ultrasound, apart from looking into that hypoechoic collection above the diaphragm, we are looking to assess the pleural line, and what we call in patient with trauma, the pleural line that we are looking into have multiple findings, inclusive number 1, what we call as a sliding sign. The sliding sign best to be viewed in the video slide, where you can see the movement of the visceral and the parietal pleura like rubbing each other. And how do we say that it is a profile? By looking into this pleural line, and there was an artifact image not the true image, the subsequent line beneath that have the equal distance between the plural line and the skin, and the plural line with the artifact line, that's what we call the A line. So that multiple A line shown here is mentioned about the A profile. And for the subsequent photo, apart from that, we also have what we call B profile, where from the plural line, you can see from the slide on the screen. So there will be a projection downward that like giving ray that diminish the what we call the previous artifact, and this is what we call B profile. The B profile could be anything. It could be like fluid, it could be wet lung, it could be a fibrosis for the patient. So let's go back for the finding about this case. The extended fast, for the positive finding noted from this case, extended fast over the left upper quadrant region. So there was two findings that we noted from the this finding. Number one, we can see this is what we call spleen. Okay, and from the spleen, there is a slightly thin lining hypoechoic surrounding the spleen at that moment. And there also fluid above the diaphragm, as we can see from the photos noted. So the impression at that point of time was to rule out solid organ injury with the left hemothorax. And as we proceed further for the anterior part of the chest, I am so sorry for the poor image on the ultrasound. However, this is what we call the presence of the A profile. And the other finding that we have at that moment was absence of sliding sign, meaning we can see the pleura is static without any movement like rubbing each other. So with this absence of sliding sign, we proceed with other finding or other measurement that we go for the motion mode or M mode in the ultrasound. And this image showed the appearance of the barcode appearance. In trauma patient, absence of sliding sign with barcode sign from the M mode, highly suggestive that this patient might having left pneumothorax. So as we scroll over further to the upper part of the chest, there was a B profile finding, which noted from the pleura, there is something project continuously downward and diminish the A line as compared to the other side. Okay, looking into this, we were thinking about at that moment, it could be the patient having a sustained lung contusion injury. And proceed with the secondary survey with the head to toe assessment. There, yes, sir.
Then after the finding, we discuss with the radiologist. That's why we proceed immediately with the CT trauma protocol.
Kenapa wujud barcode?
That barcode tentu just to say that the appearance of the finding is no moving of the pleura. In a patient where the rubbing or what we call the sliding sign present, it won't be the image of the barcode, but there will be like the seashore appearance. The sea is where the lung area, and the shore is where the artifact of the moving pleura.
Ya, bukan tahu, kalau yang normal, the appearance can be very smooth from hot to water.
Yes, sir.
That's why, I think that's what we said. This kind of thing is very on that so-called high tech. It's a bit pada shock sendiri tau. So when we have this common audience like this, then kita ada comparison what is normal. Then baru kita pasal so-called barcode, because barcode is where it's distorted. That's why you get that. Itu yang baca lah. Dan barcode sign in the morning. So kalau kita yang tak tahu, kita ingat bila kita buat apa ni grand walk round ni, it's not to show how good we are, okay? It's to teach others or to share our information with others. Kalau tidak, orang kata then you are not sharing your knowledge. So sebelum kita cerita benda yang normal, so what is normal? Sebelum kita cerita pasal barcode, what is the seashore punya appearance, dan barulah kita ni sekurang-kurangnya, yes, you will be the only one who can do the ultrasound. But when people see the at least when people review it later, they can understand why. So ni lah tujuannya kita buat network around it. That's why I insist that all the specialists speaks for themselves, so that we can teach others. At the same time, you make sure that everybody in the same language. Kita bukan nak something yang bombastic yang kita semua orang dia tahu. But lucky for me because I did reference, aku baca juga. But I think for some, aku bagus tu. So kena have that in mind that kita present. Kita bukannya nak tunjuk kita saja. Most importantly, should relate to the patient straight away. So why is happening like that? So yang saya nampak, people bila you present your case or you present your finding, try to lower down. Yes, you're sitting there very high, but you're sitting there very low. So you can ingat that. So we have to come to some same level that everybody understands. Okay?
Thank you very much for the advice. So as we continue with the second
assessment, it was noted no more active bleeding from the forehead and no depressed scalp felt. And the anterior neck was measured and monitored throughout the stay in emergency department during that moment. No step deformity over the spine. The left upper limb assessment noted to have preserved neurovascular function. I will show it later though. Working diagnosis at this moment.
Bila you start buat the examination je, kan?
Ya,
You should be working diagnosis.
Betul.
So bila
I will show you.
You're just looking everywhere now. Dia tak ada systematic that what are you looking for? Dia tak asking your working diagnosis. So kalau you start with your working diagnosis, then you tak mampu daripada deform jaw, to go to the spine, then naik balik forehead, and to balik upper limb. Given by the tempo, shoulder dislocation, so you think that shoulder dislocation or not? They mentioned that so it can go to all over the place. Kalau yang ada satu
okay, Dok. In trauma survey, or we call the assessment, it starts with the primary review. So from the primary review, as we noted on the first slide of the presentation, which I showed earlier, these are the primary survey, or we call the rapid trauma survey assessment, and the positive highlighted finding was related with the left chest injury, as well as with the deformity over the left shoulder. So as we continue, but the case assessment finding, at that moment we don't have yet. That's why I put the slide on the ultrasound finding. So from the ultrasound imaging, it showed that these are validation of the normal finding, and followed with this impression. At that moment, yes, we just were thinking about the left lung injury with the left shoulder dislocation as our working diagnosis in emergency. Because from the survey, it's just that the patient is having the skin crepitous and the reduced breath sound. It could be tracheobronchial tree injury. It could be pneumothorax.
No,
yes,
okay. Because you want to learn something from the clinical examination. I'm not really or fasting or whatever that can. Okay, you want everybody to learn something from the clinical examination, from the tempo point of view, from the clinician, from the physician point of view, from the clinical.
Yeah,
we are in the field. You don't think that we have all this because in the field.
betul.
Okay, so that dekat Lisan ada tu.
Ada tu?
Yang Islam, no, ada tempat lain tak ada, dekat aktiviti tak ada.
Ada tu?
Ada juga.
Ya tu.
Kan ada tempat lain yang ada yang distribution. Not everybody I think yang tadi tu you should get from the public survey tu, you should as a evidence physician, you can know, oh, this is my point of view, this is my clinical judgment, this is what I think that patient has. Now, I know that you have done a lot of things, it's good, but please try to bring down your levels here so that everybody can understand.
Ya tu. Agree with that. Thank you very much. That was the reason why I put the slide in the showing with the sequence manners to see about the findings. And at that moment, when we do the rapid trauma survey, we come to a conclusion with a similar referral by the primary, which is the lung injury over the left side, as well as the deformity might suggest of shoulder dislocation. That was the only working diagnosis from the primary survey. As we have the capability of performing the ultrasound bedside at this moment,
So the additional point of view facilitate us to reach to a better diagnosis rather than to say left lung injury per se, and we include some other findings. And these findings were discussed with radiologists on call at that moment. So the finding noted, which has been stated earlier, number one, with the left upper quadrant assessment, we were thinking about the solid organ injury as well as the left hemothorax. And it support our evidence of the reduced breath sound over the left lung from the patient. And as we progress further, we also noted another finding from the left lung, which we were thinking at this moment, this could be pneumothorax, as Dr. said, the skin crepitus. With the help of the ultrasound, it helped us to reach to a better assessment impression, which at this moment, this patient is most probably is having left pneumothorax. As we progress further from the assessment, we also noted the patient to have other finding, which not suggestive about pneumothorax, not suggestive about hemothorax. There are another finding from the scan itself, which noted the patient to have disappearance on the lung ultrasound assessment during EFAS. So with this assessment, the additional impression was added as a lung contusion. So these are the impression with the help of the tools that we have. It support to better diagnosis as compared to the assessment by clinical finding alone at this moment. So we do agree with the Major Dr. Shana's finding from the 21 Squadron Medic. As she said, the case referred to us with the impression of left lung injury with left shoulder injury. And complete the assessment with the secondary survey, which what we call the head to toe assessment. So during the secondary survey, there is another positive finding that we noted this patient is having. Number one, there is also deformity over the left part of the jaw. So looking into this, we are not confirmed about the finding yet, but with the discussion, radiologists at that moment, Dr. Aliruddin agreed to proceed with the CT trauma protocol and to proceed with the CT facial for the proper assessment. So, and the anterior neck was measured throughout the stay in emergency department as part of the procedure during the secondary survey. And we also noted about the step deformity was not no step deformity over the spine from the posterior from the secondary survey assessment. We complete the assessment with the neurovascular over the left upper limb, as we noted this patient is having deformity over the left shoulder. So, as we shared about the vital monitoring here throughout the stay in emergency department, those are the findings, those are the vitals monitor that was after the CT imaging, as the patient came back from the CT imaging. And with the subsequent slide, I would like to invite Brigadier General Dr. Aliruddin to share about the radiology finding that we have over this case. Thank you.
Ada buat.
Datuk, Datuk.
Tu dia tak mention.
Assalamualaikum. Okay, continue with they do the chest X-ray first, supine X-ray at emergency department. So these are mobile X-ray done in ED. So on the first, we concentrate on the first. Okay, we concentrate on the film on the left side first. So this supine AP film showing the obvious the abnormality on the left side. You see a different density of the lung. What you see the right side is looks clear, normal, heart size appear normal, but on the left side it's more dense, okay? More whitish compared to the right side. So there's a bit of deformity, artifact. Maybe patient shortness of breath or something like that. So it's moving during the shooting of the X-ray. So there's a bit of an area of a darker area, suggestive of a bit of air, and also it's subcutaneous around the scapula. But the left clavicle appear okay. There's no fracture there, but we noted that the left shoulder dislocated anteriorly. So the second essay on the right is to show more concentrated, is focused actually on the left shoulder, showing the anterior dislocation of the left glenohumeral joint. Okay, at the same time, but we don't see any fracture of the adjacent rib and also the clavicle. So after discussion, ED referred for CT scan trauma protocol. But we worried about whether patient had any history of allergy or patient any history of actually drug allergy or something like that, or dehydration. Because for CT protocol, we need to give an IV contrast. So it's important that it's a consent given before giving a contrast, and we make sure that patient whether got any injury to the brain or not. Because if any trauma, we suggest any intracranial bleed. When giving IV contrast, patient might have hitting because contrast can cross through the blood-brain barrier. So so we do the plain CT brain and neck first to assess the thing, followed by contrasted CT thorax, abdominal, pelvis for the evaluation. So I just show here a few of the interested images. There, there's a ventricle, there's no bleeding there, the brain is okay, and there's no intracranial bleed or contusion. This is a soft tissue window. It's not a brain window, or it's not the bone window. It's just a soft tissue window. So during this time, we see there's an air pocket at the mandible, left side of the mandible. So on this window, we not see any. The main thing we not see bone because it's not a bone setting. Okay? We just send later we convert the windowing to bone window, then we're going to see the bone part. So this part is just to see the soft tissue, right? So lower down, okay. We can see more of the subcutaneous emphysema. The trachea is there, so in the center. The thyroid is okay. So at the posterior part, there's no hematoma to the left side. Going further down, you start seeing the more inflammatory area. These are on the mediastinal window, right? On the mediastinal. So start see a bit of hemothorax there. Further down, you can see more. So at this time, you see you do not see this on the right side. You don't see any effusion. You see a clear dark area. It's mainly more for the lung. Okay. Later on, I show you the lung window. Okay. So lower down in the abdominal part, the liver looks okay. The capsule intact. All right. There's no fluid there, but because there is an urgent CT, so we don't give any oral contrast. So the problem is because a patient at the same time also cannot raise the hand. So there's going to be artifact from the humerus to the side. Okay? So if a normal patient, we elective cases, we're going to give a contrast so we get more contrast in the stomach. Okay? So, but we saw there's a fluid around the spleen. The spleen, there's a enhancing part is a normal spleen. You see a dark line in between. Okay, about 3 cm there. We got a bit of blood around it. Okay. So when we convert to lung window, okay, I thought initially there's also the pneumothorax on the right side, but actually it's just bulle. Okay, at the apical region, the subcutaneous emphysema there. So the right lungs is okay, expanding. Okay, then coming down, you see this area of dark area. We call it a contusion area. The contusion area can be due to direct impact or can be due to the blood in the alveolus. Okay, the quite clear area is the lung. It's a partial collapsed lung. So the darker area is the air, there's pneumothorax. So this is a fluid level. Okay, this is blood collecting posteriorly because of the gravity effect. Okay, this area is a contusion area posteriorly. This is a partial collapse of the upper lobe of the lung. Then there's a pneumothorax and also blood. Okay, this on the lung window. So this one is coronal view. Just now axial view. Coronal view we cut vertically. No need to further scanning. Just a computer do it. So this on mediastinal window. You see the area of contusion, hemopneumothorax. Dark area appear like area of that clear, right? So these are the lung. Then there's like the lung or partial collapse, contusion area, the free air in the pleura, the pleural effusion. Then the C part of the liver, okay, right kidney, left kidney. And there's an area of the spleen where we can see the collection there. Okay? A lot of dark line in between. The spleen is perfused well, okay? Perfused well because there's the during trauma, so we have to balance within the timing of an injection of contrast because we want to see any area that, especially the hilum of the spleen, hilum of the kidney also, because we want to see whether got a major blood vessel injury. Okay, because it's a big vessel, it's going to bleed a lot if there is a involvement of the hilum where all the blood vessel lymphatic nerve pass through. So more focus to the spleen area. So there's a fluid in the stomach, part of the left kidney. So this is spleen. There's a perfusion area, looks okay. There's a dark area, is all the laceration. You got few lines there cross. It's not that, it's not really passed through and through. It's not a fracture. Okay? The fracture can be, but just I see an area like this line. So it's like crossing through. So it can be a fracture area, but we don't see any pulling of contrast around the splenic area. If a pulling of contrast is suggestive of a splenic artery injury or splenic vein injury. So just to show this, that surgeon going to explain more. So this staging of what we call spinning injury classification. So this patient is more of this type because there's no involved major or splenic vessel. Okay? So this is going to. So for when we go to the bony part, okay, this is a bone window. Okay, we see more of the bone area and compared to the other part is a press. So all the soft tissue will not appear going to be well. This is because we highlight the bone. All right, we see the fracture. This is a glenoid. Okay, so we see near the spinous process. There's a loosened line there. Here got an air pocket, multiple small air pocket. This is a fracture line near the spinous process. So on 3D recon, you see the anterior dislocation. You see the fracture line. But it's not crossing up to the edge of the medial border of the scapula. Right? At this part, we don't see any fracture rib. So later on, I show you our 3D recon. So when we remove the scapula, we saw there's a fracture line here. Okay? This is a third rib posterior. It's a displaced fracture. There's a anterior dislocation of the left shoulder. There's a fracture of this undisplaced fracture of the scapula, left scapula. So there's for this time more of an impact is more on the left posterolateral impact. So although on this even on the X-ray we don't see any fracture of the distal rib or the lower rib. So for young patients, sometimes the rib is still flexible. So doesn't mean there's no fracture. I mean there's not going to be internal organ injury. Yeah? So sometimes we don't. So there's no rib fracture doesn't mean there's no injury. Right? So for this skull, there's no after when the brain is okay, but the swelling not in the frontal side and also near the mandible area. So on the bone window, we see there's a fracture line there crossing through, a bit transverse. On the parasympathesis area, there's another one here crossing through. So on the sagittal view, there's the angle of the left mandible and also in the left parasympathesis region. But for 3D, this is where the fracture line is quite displaced compared to that's quite common area. Okay? It's a quite common area. These are among the common area for the fracture of the mandible. All right, that's an X-ray part only.
Okay, sorry, Dr. Naya. Setelah daripada working diagnosis tadi, we go straight to CT scan. Okay, will that any different kalau kita bypass the ultrasound just now?
Yes, because but there's a part of usually they do the general X-ray first, mobile X-ray, then we do the injury of the lung or not. For abdominal part, there's an ultrasound. But looking for how severe the lung contusion is with pneumothorax, usually we proceed straight to CT if you are available.
But because I'm just looking at it from this case point of view lah. Yeah. I mean, we have to treat different case differently.
Yeah. Because
now kalau kata the more sign to the abdominal injury, yeah, maybe ultrasound can come in first. Yes. But dalam hal ini, you can go straight to CT scan pun saya rasa tak ada masalah kan? Yeah. Why? Because the time is the essence. So itu yang kita tak nak. Hanya kerana kita nak buat satu prosedur, then we delay the eventual treatment. So ini yang kita kena faham. Yes, we have modalities in our system, but we have to really assess whether there is a need or not based on the individual cases.
Yes.
So kita tak boleh generalizekan itu yang saya cuba masukkan. Sebab saya rasa dalam hal ini, maybe the ultrasound may not be the first priority pun based on the chest X-ray. Kita dah tahu dah, and the nature of injury it involve the upper chest. And so itu yang kata kalau kita straight to CT scan, So saya tengok tadi pun tak ada betul different finding yang sekian lah yang boleh contribute ataupun yang boleh menambah lagi apa yang be detected dekat CT scan. Kan? So itu yang kita nak kena faham lah. Maksudnya dekat IP, I don't know, mungkin untuk distribusi kita lah tu.
We do the CT scan at 1750.
No, how long is the time when the request for CT scan? How long it takes?
25 minutes after patient arrival.
25 minutes after patient arrival.
35 minutes, we will directly.
I do the scan at 1757.
Let's say that we are not around and the CT scan is not available. By looking at the X-ray, just a normal X-ray, can you make any decision how to manage the patient in terms of the lung problem? Do you need to put the test tube, whatever? This is what I'm not sure what that's going to be.
If you have a good clinical and can suggest pneumothorax, then
yes, there is one thing is that your clinical judgment, you see from the X-ray and the shoulder dislocation, I think you can reduce the shoulder immediately. Kan, takkan nak tunggu sampai CT scan pun nak reduce the shoulder. That's what I mean. You nak sampai sampai MRI baru nak buat something.
That's the thing. Patient is in pain. That's the thing.
This is the thing that you have to do something now before. Looking at the chest X-ray itself, something is already on the left shoulder, the left lung. And I surprised when I see the CT scan, the shoulder is dislocated.
Still dislocated. So that's the thing. So that's the thing. Our astrology is easy. Stabilize your patient first. Do whatever you need to do, and patient is stable. Then you send us, because the scan is very fast. What 30 seconds? Just prepare.
I'm not saying that. I'm just asking. They say the timeline, the scan, the CT scan is not available at that time. Maybe you're not around, and then we need to wait for CT scan to manage the patient, which is not. I think it's not right. From the X-ray itself, you can see it's very obvious that something needs to be done for the left lungs and the left shoulder. At least reduce the shoulder. Tapi mati saja. Sampai CT scan baru ada dislocated.
I agree with that.
Betul tak? Because I mean that things that you cannot just rely on your machine. Your clinical judgment must be very right, and then you have to. We learn from history, physical examination and simple investigation. By then also we can get our diagnosis and can do something before we go to the further high-tech technology investigation so that we can go further. I think this also we can, whatever the mobility that happen, we can reduce the thing.
That's that we will try to teach the one in the periphery.
I'm not saying that we shouldn't go in the more high-tech, but on the basic, I'm old school. I think most of us in old school. I think we don't learn all this during last time then. And then we do what we can do during all the basic investigation. We can do a lot of things. Okay?
I think I pun agree juga. Sometimes within the procedure of the scan, the patient boleh diturunkan. So I think saya pun sama dengan pandangan pada Pak Amir. I'm not comfortable seeing a dislocated shoulder on the CT scan. Right? At the same time, patient ada masalah breathing, oxygenation. So I think kita kena address left lung injury tu. If we decided for a chest tube, so I think go for that.
Go for the chest tube first.
Tapi yang berfikir tu ultrasound in emergency department. So memang kita buat ultrasound tu kita nak rule out kita apa ni injury kan, injury.
If the technology is there, no problem.
Tapi kalau the chest X-ray kita clear cut, kan, I think you can bypass the ultrasound tu and just for security. It's about I think.
Thank you very much, Dr. Talibudin. Yes, if I may correct, Dr. Dato, for the In terms of the chronological timing of the incident, when the patient arrived about 5:20 p.m. at that moment, when the assessment was done, yes, the impression was noted as followed. And the CT imaging, luckily, Dr. Ali facilitated to do that early. And even it was before the chest X-ray film was printed. So that was the finding noted. So we would like to share in this grand round about the chest X-ray finding over that patient, looking into retrospective review. But then I do agree in the polytrauma patient, with the help of the certain imaging, you should reach to a certain management immediately. So in this case, I would like to continue with what we've been done in emergency department around 6 p.m. when the patient coming back from the CT room at that moment. So we decided to go with these three approach. Number one, about damage control resuscitation in view of the patient having slightly accepted mean arterial pressure. So there was no fluid aggressiveness was given. And the patient was started on the IV tranexamic acid 1 gram that is based on the what we call the crash through protocol trial. And the early blood product with the full blood count results showed the hemoglobin was 7.0.
Okay, and sekali lagi, sekali lagi nak tanya lah kan. So you start tranexamic ni dah dapat test X-ray ke, dah tengok CT scan ke, belum?
This moment selepas balik daripada CT imaging, betul.
Okay, so you already rule out apa tu X-ray.
We look in
because again lah kan, when aku belajar masa hospital dulu lah kan, because tranexamic acid ni you can only administer until and unless you confirm that there's, because this is supposed to be for closed cavity bleeding. Okay, as closed bleeding, dia bukannya apa tu kata open, so that but it will give more harm than good. So this is the thing, something that we all have to learn. Yeah? I'm lucky I've learned that during my hospital. That belum you bagi tranexamic, you make sure that the bleeding is arrest or rather is confined. Macam kalau kata apa tu hemostasis ke, then you can give. But kalau dalam trauma, then you have to be very cautious. But I don't know what it is now. Yeah? Because I lost my first out berhubung. So this is the thing yang I want to confirm lah.
Yang bagi Dato', thank you very much for the very excellent comment. Yes, we do agree on the tranexamic acid is by recommended for the closed compartment bleeding. And this patient was given, the decision was decided after CT imaging, as our radiologist advised us in view of this patient having what we call the lacerated spleen. It supports the evidence of the intra-abdominal injury, which we was looking into the solid organ base during our first assessment. And based on the crash 2 trial, the recommendation for this tranexamic acid, the good outcome is only shown if it was given 3 hours, within 3 hours post-trauma. So anything that given after 3 hours post-trauma will have the worst outcome rather than the benefit of giving tranexamic acid. And yes, thank you Dato' for highlighting it. In view of giving tranexamic acid, the current recommendation is only to be given within 3 hours post-trauma. So if let's say we bypass that time, it's no longer recommended in any trauma patient. Yes, Dato'. Closed compartment meaning intra-abdominal by crash study, yes, it is supported to be given in a patient. Even in crash 3, they go for the what we call the intracranial bleeding furthermore. But those finding only positive effect if be given within 3 hours of trauma onset. And for the left shoulder dislocation, it was reduced by using spaso technique, and I will share a little bit on the image of the spaso procedure. And the chest tube was inserted with the size of 32 franc using open method. I was monitoring for the hourly drain at that moment because we are looking into probability of this patient having massive hemothorax for the cardiothoracic referral. And looking into the spaso technique, is one of the easy method that we can share with all the MOs and the MAs, including the paramedics dealing with the shoulder dislocation. So Spaso he is a nurse where he find one of these procedure is doing a simple just flexion of the shoulder anteriorly, okay, and then followed by lifting of the shoulder and externally rotate. With that, that's how the reduction will occur spontaneously. And this patient, after being given the ketamine for the analgesic as well as for the sedation analgesia, and immediately the simple procedure reduced this shoulder dislocation for the patient. So just to continue with the diagnosis post-imaging, we come to a conclusion about these 5 diagnoses. This patient was sustained from the left hemopneumothorax with lung contusion, as well as the third left rib fracture posteriorly, and the grade 3 splenic injury with the left scapular body fracture and the mandible fracture of left parasymphysis and the angle of mandible. So looking into the discussion, little bit on the what we call the trauma procedure. Rapid trauma survey that we showed earlier is actually part of our national trauma survey. It was meant to complement the standard practice and not to replace the national standard. And you can see that the usage of the rapid trauma survey can be done easily in the pre-hospital care setting to facilitate our pre-hospital care team to detect the injury better. And we do respect the team in 21 Squadron Medic GGK. They did quite well in their assessment, and with the help, it can facilitate them better. And the next part of the discussion, we showed about the damage control resuscitation, as that highlighted before. The role of IV tranexamic acid is only recommended in crash to trial within the 3 hours onset of the trauma. It's not to be given in a patient where the trauma is already exceeding the 3 hours period. And there is a role of early blood products to prevent hemodilution. In this case, as we go for damage control resuscitation in patient without head injury. And the targeted blood pressure for the MAP is around 65 millimeter mercury, is enough to prevent coagulation dysfunction without compromising cerebral circulation. So I would like to call upon our next colleague from the surgical team to continue with the case progress.
Thank you very much, sir. So I'll continue the presentation on the referral to the surgical team part. On examination, E4, V5, M6, his GCS was full, the airway was patent, pupils bilaterally reactive 4 millimeters, afebrile, speaking in phrases to sentences then. Based on the CT findings and also clinical examination, first was due to the left hemopneumothorax, secondly due to intra-abdominal injury. He was speaking in phrases and sentences, left jaw asymmetry, equal chest rise. There was crepitus felt anterior left side of the chest. He was tachypneic with the RR of 26. CRT is less than 2 seconds, good pulse volume and warm peripheries. BP then was 107/52, pulse rate 76, temperature afebrile, SpO2 was 100% under face mask 5 liters. CVS rhythm murmur, lungs, there was reduced air entry over the left lung. Chest drain, 32 frunk was in situ with 300 cc's of blood functioning. For abdomen, generalized guarding, EFAS done in emergency department, there was free fluid in the abdomen and left lung absent sliding side. Our main issue at that time when we received the referral first was to deal with the left hemopneumothorax. We were hoping that there was no massive hemothorax, whereby the definition goes spontaneous output of 1,500 mils of blood on insertion of the chest tube, or 200 cc's per hour for the next consecutive 4 hours. And there was none, thankfully. Our working diagnosis was polytrauma with left hemopneumothorax, left third posterior rib fracture, grade 3 splenic injury, and fourth was good responder to fluid resuscitation. The patient was resuscitated according to the ATLS protocol and counseled for emergency laparotomy and proceed. Teleconference was done between Colonel Dr. Mohammad Wazir, who is not present here at the moment, the patient and his wife that lives in Sarawak for informed consent of the procedure. Shortly, I will discuss regarding the option of why we proceeded with emergency laparotomy. This was the teleconference done between the patient, our surgeon, and also his wife at Sarawak. Proceeding with the chronology of events post-CT on 20th August 2021, For the left hemopneumothorax, the ongoing blood transfusion of 1 pint Paxil and 2 units FFP were done in emergency department. Left thoracostomy was done at the safety triangle under aseptic technique and drained in total about 500 splits for that. The left shoulder anterior inferior dislocation, spasmo technique was used with CMR for this patient, and also for grade 3 splenic injury and comminuted left mandible fracture. He was counseled for emergency lab for the splenic injury by our surgical team, and concurrently was seen by the OMF team for stabilization of fractured mandible fragments and hemostasis. Next, we will go on to the AST spleen injury scale. In blunt abdominal trauma, it accounts for majority of more than 80% of abdominal injury. It's also responsible for substantial morbidity and mortality. The prevalence of intra-abdominal injury itself among patients that actually present to our emergency department is about 13%. Spleen and liver are the most among injured solid organs seen in intra-abdominal injury. The mechanism of injury in this patient itself, there was a sudden rise in increased intra-abdominal pressure created by the outward forces that could cause a rupture of an organ, which actually happened in this case when he was swung by the tree trunk itself. The blunt forces exerted against the anterior abdominal wall usually could compress the abdominal viscera against the posterior ribcage or the vertebral column, causing a crushing force. So that was what we were thinking of at that moment that caused his intra-abdominal injury. Solid organs, basically such as liver and the spleen, are particularly susceptible to lacerations or fracture by this mechanism itself. Hence, it is why we always consider the evaluating clinicians to always recognize that the absence of any abdominal pain, any tenderness on physical examination over the abdomen could not actually rule out intra-abdominal injury itself. So we'll proceed with the AAST spleen injury scale for this patient. To simplify it further, Dato, I'll just go on to the next slide over here. So the splenic injury grade according to AAST has 5. If you can see the first picture on your left-hand side, the laceration less than 1 centimeter and subscapular hematoma less than 10 centimeter. Sorry, Dato. So grade 1 would be laceration less than 1 centimeter and also subscapular hematoma less than 10% of surface area. Grade 2 will be laceration of 1 to 3 centimeters with subscapular hematoma 10% to 15% of surface area. Grade 3 would be laceration more than 3 centimeters with subscapular hematoma more than 50% of the surface area. Grade 4 would be segmental or hilar vascular injury, which was not seen in this patient. And grade 5 would be hilar injury and shattered spleen. Now, according to the CT traumatic protocol findings, he was graded as grade 3, whereby the laceration was more than 3 centimeter and subscapular hematoma of more than 50% of surface area. In hemodynamically stable patients, hemodynamically unstable patients with positive fast findings typically go directly for operating room because of in view of instability and also for emergent laparotomy. So the next slide, I'll actually speak about the spleen trauma algorithm according to AAST, American Association of Surgery in Trauma. So if you can see here, Dato, spleen trauma in the ED with positive fast findings in thoracic or pelvic X-ray would actually progress to hemodynamic instability or transfusion responder, which was seen in this patient, whereby he responded to fluid resuscitation at the emergency department. However, in view of positive E findings, we would grade it as AAST 1 to 4, whereby the next management would be laparotomy plus minus splenectomy with splenic salvage. Another non-operative management could be used in this patient, but however, due to lack of resources in our hospital and also in view of we don't have an interventional radiology staff, whereby he could have or she could have basically performed angiographic embolization to actually proceed with non-operative management for this patient. Hence, this patient was counseled for laparotomy plus splenectomy. The surgical management required in such patients actually fall 20 to 40% with patients with splenic injury. The open surgical techniques are actually the current standard of care in institutes whereby we don't have enough resources. The hemodynamically stable patient in trauma with splenic injury identified on CT scan itself may be initially observed and undergo angiographic embolization if an IR is actually present. But like I said, in our setting, we don't have an interventional radiologist, hence we proceeded with an emergency laparotomy and proceed with this patient. Patient-centered approach, if you can see on the screen, spleen hemodynamically stable usually will be given two options via their risk profile, unable to tolerate rebleeding or able to tolerate rebleeding. In this patient, because of his progressively worsening condition in view of abdominal guarding, we had to proceed with splenectomy itself because he was unable to tolerate rebleeding. In the operation theatre, perioperative preparations, we shifted the patient from emergency department to our OR at about 10:30 p.m. Noted that the patient was actually hypotensive and oxygenation was desaturating in OT during intubation. This was at 23:10 hours. His vitals then was 95/60, pulse rate 102. He was already tachycardic. Temperature afebrile and SpO2 dropped from 100% under face mask to 90%. His chest drain was 500 cc's and it was not functioning. We realized that his chest drain wasn't functioning, hence it was readjusted perioperatively, and second Paxil transfusion was commenced in total of 3 pint Paxil and 2 units of FFP. Post-adjustments, vital signs were stabilized and oxygenation had improved. For the next slide, I'd like to call my colleague, Major Dr. Fuad, to continue the presentation.
So, first, the surgical site. This is always
Yes, sir.
right. Normally, when we look at the protocol for the spleen injury,
Yes, sir.
and we're so keen to go to see the infra act issues, right?
Yes.
Hence, the team decided for laparotomy and PID.
Yes.
If the team ever consider that the chest, the lung injury may worsen the patient intraoperatively. So my question is, do you think that Tenera would be the best center to handle this particular case, or rather we should send to somewhere at an advanced level hospital? Do you all anticipate that this patient might deteriorate because of lung injury?
Thank you, Dato. Yes, we did anticipate that. Hence, our anesthesiology team actually stood by with a bronchoscopy to do intraoperatively for this patient. We will then show what exactly happened in OT shortly, Dato. Thank you.
Assalamualaikum, Dato. I'm the Major Dr. Fuad. We will be presenting on behalf of anesthesiology department. So for the event of acute deterioration post-intubation, we need to think of 4 causes usually. It comes with an acronym of DOPE, D-O-P-E. So D is a displaced ETT, which is ETT maybe go to the mostly on the right side. O is the obstruction of ETT due to secretion, blood, pus or any foreign bodies. P, pneumothorax. E is equipment failure. So in this case, the case is P, which is pneumothorax, which is the failure of the chest tube, which is after the readjustment of the chest tube, which is we push further, the patient condition become improved. Dato'. Maybe due to the transfer, when the transfer patient on the OT bed, Dato'. From the stretcher to the OT bed, when they pull, they transfer the patient, the suture is not that good. So when we reassess back, we push further, so we see the underwater chamber is working, and then patient condition straight away become improved. So and then we resuture back. First, in the first place, I think need to proper suture And then second is when you transfer the patient, you need to be more gentle and also fully coordinate. So, emergency department itu.
Yes, sir. It was done, observed by me and done by medical officer, and it was done with the open method technique. Yes, we do agree on the what we call anchoring method. The tie techniques is not that excellent to prevent it from the what we call moving chest tube at that moment. Uh, Maksudnya for me at that moment, my judgment to say that it is a good procedure. Then we realize when we get the feedback from our surgical colleague, it should be done better because that's what happened intraoperatively. The patient having this what we call episode of desaturation. So looking back into our methods, yes, we have that what we call the weakness in this technique. Different. Mungkin dengan saya, it was with me, it was her first time.
So you rasa it's good with the kind of case to allow first timer? Yeah, I know it's benefit of learning, but sometimes you have to really pick and choose. Okay? It's not that it's not patient. So itu kita sebagai pakar, sebagai senior, then you have to really like balance it out. Dan kita hanya kena okay, kita berapa sensitif, okay, kita buat tengok. So kita tengok baru kita outcome. So dari segi judgment is very important. Yeah. Lepas tu saya tanya berapa kali dia dapat. Kalau for the sake of first time, yang dia nak mengajar dia, this is a right case lah. Okay. Cuba bayangkan kalau abang kau terbaring kat situ agak-agak. Kau akan buat ke, kau suruh Epo lain buat, kau akan tengok.
I will do myself.
Yeah.
So
that's the baseline.
True.
Kalau kita nak buat apa-apa, kita tengok, is it the right time? Yeah, I'm not against teaching and learning, but you have to do it in a very conservative manner. Kalau patient yang stable and learning, maybe you can come just contact the motor and tak ada isu lain. Yes, you can allow them to go for first try. The patient that eventually end up in the OT, I think that is not a wise decision. You have to please be more serious on this issue. It's a fact that everybody talks about this case. But then in any situation, when you want to allow people to learn, you have to be very careful. And most importantly, kalau you really want to let them learn, then you have to be extra cautious and tengok betul-betul. Because kita nak benda-benda ni berlaku because of species negligence. Because they are not doing it properly, and because of that, they cascade on fact. And kalau kata the chair 2 was working properly, then do not succumb to it. You need to reduce the circulation of that. Macam ni lah yang kita ambil responsibility lah. So jangan anggap you can train anybody, especially online patient like this. We have to be the intervention first. They can watch you do rather than you ask them for the first time. No. Kalau for the second time, that's okay. For the first time, that is not the best practice lah. All I can say.
Thank you.
I'll continue from here for the surgical management account. The intraoperative findings, emergency lab and splenectomy had intraperitoneal pooling of blood approximately 1 liter. There was the chest drain which was functioning currently with 500 cc's of blood, multiple laceration wounds over the posterior surface of the spleen, multiple mesenteric contusions, but there were no other injuries seen intraoperatively between all four quadrants. The liver was also spared from any injury. It was a multidisciplinary team approach, and we commenced OT at about 11:30 p.m. As you can see in the picture, it was already at 12:35 a.m. Post-operative measures. The patient was transferred post-operatively intubated to our ICU for observation. He was commenced on hydration, on antibiotics, which was IV rocephin, IV pento, PCA morphine as per the NS team, IV bromhexine, napsaline, keep the urine output more than 30 cc's with the MEP of more than 65 and SpO2 more than 95. These are basic management post-operatively for any patients that are unstable. Next, I would like to proceed with the anesthesia team.
So for the perioperative assessment at ED, GCS of the patient is full, multiple abrasion wound over left side of the face and neck, airway limited mouth opening, complaint of pain over chin and jaw, hemodynamic stable, not tachycardic, 1 pint PET cell is ongoing, SpO2 98% under face mask 5 liter, lung reduced air entry at the left lung, chest tube in situ, well function, drain 500 cc blood. CVS normal, per element tender and guarding, urine output is good, 2 big line over both hands. Anesthetic concern at this time is patient is not fasted, and this is a trauma case. So there is a risk of aspiration, need for rapid sequence induction technique, difficult mouth ventilation and intubation. So we prepare this case for the intubation with video laryngoscope. Bleeding resuscitated in ED with crystalloid and ongoing transfusion 1 pint PET cell, another 3 pint PET cell and 2 unit FFP are prepared. IV tranexamic acid 1 gram over 10 minutes given and 1 gram over 8 hours according to the crash studies. And potential for difficult ventilation for mechanical ventilator due to left lung contusion and also total collapse is ensured by the left chest tube well function and good drainage system. Intraoperative intubation done with a video laryngoscope, but during the procedure, left parasymphysis fracture displaced and bleeding continuously. Unable to stop with gauze compression, immediate consultation with the referral of dental team done on the table. Hemodynamic deteriorated post-induction due to the loss of sympathetic reflex with due to anesthetic agent. Unable to secure the bleeding from spleen and bleeding from the dental region. Lowest BP is 60 to 40, with heart rate is 40 to 50. Vasopressor was started. This is when we only give phenylephrine and also ephedrine. Little triad avoided, hypothermia, acidosis and coagulopathy. Keep patient warm and also avoid acidosis. After transfusion of 2 pint PET cells, splenectomy done, bleeding from dental area secured, hemodynamic becomes stable and able to off vasopressor. Estimate blood loss is 1 to 2 liter. So this is the picture of intraoperative. This is the picture of the spleen. There. Post-operatively, hemodynamic stable, no hypothermia, ABG, no acidosis. Issues is extubation post-op failed due to the respiratory distress secondary to possible blood aspiration before the intubation because of the blood clot. Reintubation back done by the followed by bronchoscopy, and then after the bronchoscopy, the blood clot is removed from the right lung. This is a bronchoscopy done by the anesthesiologist. Post bronchoscopy, patient was admitted to ICU around 3 morning for lung recruitment and also weaning from ventilator. Repeated chest X-ray in ICU showed that no consolidation, blood aspiration on the right lung and also the left lung, good expansion. Day 2 extubate to face mask 5 liter, multimodality anesthesia given, PCA morphine, NSAIDs and also IV PCM. Chest physiotherapy and incentive spirometry can be started as early as possible, and the patient discharged well to the ward on the day 3. Issues that I want to highlight here is a multidisciplinary approach by all the teams, and also pain control, which is need to be multimodal. Chest rehabilitation need to be started as early as possible, and also post-splenectomy care is a duration of antibiotic and vaccination requirement. Second operation done for ORIF for mandible fracture. At this time, we use nasal intubation with video assisted laryngoscope on the day 6 post trauma, and the operation is uneventful at all. Yeah. Issue for multidisciplinary approach is need to be because in the OT at that time need to at least ada many teams in the OT is anesthetic and also we call dental team and also surgery team. So many teams need to take part in this operation. Second is pain control. So we need to give more than one analgesic. So we give PCM and also morphine and also dinostat for this patient.
Okay, before we go further, dental patient kan?
Yeah, betul.
Okay. So what happened to this patient now?
Okay.
Okay. Of course, the patient, I'm asking the doctors attending now, what happened to the patient? So sekarang ni ada follow up kat mana? Dekat klinik, dekat Tengah balik? The doctor. I'm not asking the patient, I'm asking the doctor.
Okay, Dato', the patient is currently under follow-up with the OMF and the surgical team in our hospital, which was the last seen. We will see the patient progress later with the latest review.
Okay, last vaccination bagi apa?
Sorry, the last vaccination beri apa? He was given with the Haemophilus influenza and meningococcal and pneumococcal. Okay.
Janas, mana dia apa? Kenapa kena bagi pneumococcal? Ya, kenapa kena bagi pneumococcal di sini? Tengok dekat apa ni, jawab. Kenapa in this patient kita kena bagi pneumococcal vaccination? Ha? Ambil mic, bagi mic dia. Ada soalan tak? Boleh?
Because this patient already removed the spleen.
Ha?
Because this patient already done
Itu sebab si tidak beritahu kau ke belakang. Kan? Saya ingat dengan pakai mask tu tidak kau tidak tahu. So kenapa bila remove spleen kau kena bagi muka kau vaksin? Ha? Kenapa? Why? Kenapa kita kena bagi muka kau vaksin when you do the spleen cleaning? What's so special about pneumococcal? So benda-benda macam ni penting, ya, because this is MO level, bukan specialist level. So that's why I tanya confidential of care, because until and unless you understand what the patient need, why they need, the benda will not be followed up properly. That's the thing. Sebab kat bawah tadi kau cerita pasal lung confusion, kan? Ni atas dia cakap pasal splenectomy. But at the end of the day, you don't know why you need to give pneumococcal vaccine to patients with splenectomy. So itu yang lebih penting. Dan understanding. So mana lagi yang siapa boleh jawab?
Baru ni, kita semua tinggal kita jadi MO lah.
Okey, betul. Ini yang jawapan campur kan. Because one of the rules of this is to remove capsule of bacteria. Okay, for it to be exposed to your system. Pada chemistry, definitely will become the capsule of the local bacteria over there. That's why you need to protect yourself against the That's the very reason. Okay. In this case, all tapi specifically why? Because this is the most so-called virulent or the one that responsible for the infection. Same goes to medical doctor. So benda-benda macam ni you faham, kita tahu. I know mungkin it's not mentioned in one line of your book, mungkin your lecturer tak bagi tahu. But along the process, you have to understand. Bukannya just take it for granted and you assume. Yeah, my always famous word is assumption is the mother of all fuck and it works as well. Yeah. It's apply here. So you tak boleh assume without understanding why it is. Sebab apa? At the end of the day, kebanyakannya treatment failure or follow-up failure, not because of anything, because of our failure of understanding the need of that. So kita akan kata take it easy. So sebab kita faham, kalau dia tak dapat minum pneumococcus vaksin pun, atau meningococcus vaksin pun, dia tak apa, sebab dia tak pergi Mekah. Sebab dia nak pergi Mekah, baru dia ambil pneumococcus, dia nak pergi Mekah, baru dia nak ambil meningococcus. Because you don't understand why in this patient is required. And patient with splenectomy. Okay?
Good morning, Datuk, senior officers, and all my beloved colleagues. Oral and maxillofacial team is involved in the management of facial trauma. So we are involved in the emergency and also definitive management of the facial fracture. From this side, I wish to give you an overview of the facial fracture injury. As you can see here, there are two fracture lines, one at the left parasymphysis, and also the other one very obvious on the left mandibular angle. And there is some fracture incomplete at the Lefort 1 level. And then there are also some soft tissue injury, laceration measuring 3 centimeter by 1 centimeter at the forehead, only extending to the frontalis muscles, not to the bone. And you can see that from the slide here, the next slide here, there's some abrasion wound on the left cheek. Intraorally, the fracture is very displaced and very mobile. And here you can see a premature contact. And then there's shortening of posterior ramus height. And the occlusion is deranged, some swelling here, and bleeding was profuse. So in the first operating theater session, we did some damage control surgery. We control bleeding, make sure the bleeding doesn't affect the airway, and also try to facilitate the works of other team members, especially the anesthesists, because we share the common area of intervention. So 6 days after the primary surgery, we did the definitive management, which is to do the or open reduction and internal fixation. So I will just give you an overview of how we do the fracture reduction. So we start off with MMF, maxillomandibular fixation, which is to do the wire fixation, establish the occlusion, because occlusion acts as a guide to where we place and position the fracture. And once this is settled, then the fracture will align themselves bit by bit. So this is also a continuation of the maxillo and mandibular fixation. By tightening the wire, make sure the occlusion is right, the teeth are biting right. For the upper jaw, we place an arch bar. For the lower one, we do an eyelid wire, because for the upper one, we got a complement set of teeth. We got enough teeth to place the arch bar. Arch bar is a more, I would say, easier option to use. Compared to the lower jaw has got not enough teeth, and then they are spacing. So if you want to place an arch bar, it is quite a challenging task. So to make it easier, we place an eyelid on certain tooth. Here, in this case, we put it at the lower first premolar, lower right first premolar, and also the lower right second premolar. And the other side, on the left side, also on the lower first premolar and also the second premolar. So intraoperatively, once you expose, okay, we did the incision, just a vestibular incision. From you will make a cut on the mucosa and then extend, and then you can see a muscle. Once you expose a muscle, you can see the fracture is very displaced. Here, you can see this is almost the half of width of tooth. A normal average width of tooth measure about 7 to 8 mm. So this is slide is to show that my boss, Brigadier General Dr. Das, myself, and also Dr. Maisara were working together to manage the case. So we did the normal standard open reduction and internal fixation according to the Shamfi and Michael principles, which are to place 2 plates in front, 4 plates, and also 1 plate at the left mandibular angle at the external oblique ridge. And then this is the upper plate. There are 4 holes, okay, and using Sintis 2.0 millimeter system. And we stabilize the fracture, and we move on to placing the lower plates using the universal screwdrivers. Okay, now you can see 2 plates are in place. Okay. And we are doing meticulous suturing, closing the area. This is one side, and then the other side is at the angle. We also take out the wisdom tooth, because the wisdom tooth is in continuation of the fracture line, and this tooth here is badly decayed. So there's a high possibility of infection if we don't remove the tooth. So once everything is done, and then we check the occlusion, make sure the joint is moving in the pre-injury position, and the mouth opening is good. We do meticulous closure with YPIL 4.0. So this is the post-ORIF OPG. You can see here the fracture is nicely fixed. 2 plates at the left pars incisive area and 1 plate at the left mandibular angle. To give Dato and Tonton an overview of what we have been doing for the patient. We have already reviewed the patient 1 week after the operation. The occlusion was stable, function was good, openings was good, and then we did a review 3 months later, and then the function is also good. Mouth opening continued to improve, and the patient is able to chew.
And we plan to do another follow-up in 6 months' time. That's all for my part. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. Is the orthopedic management for this patient. There were two orthopedic issues in this patient. The first one is left anterior shoulder dislocation, and number two is close fracture of the left scapula. For the dislocation on the left shoulder, it was successfully reduced on the first attempt by the EP specialist under sedation anesthesia using spatial technique. Later, the arm was stabilized by using the arm sling. There was no neurological deficit post-reduction. For the closed left scapular fracture, is an uncommon fracture to the shoulder girdle, usually associated with high energy trauma, such as in this patient. Is less than 1% of all fractures in our body. In this patient, the diagnosis was based on physical examination. There was a tenderness at the spine and the body of the scapula, and based on radiological examination by using the plain radiograph and CT scan. On this X-ray, actually the X-ray we cannot see obvious fracture line. It's very difficult because the scapula is packed with muscle back there. On the CT scan, we can see there is a fracture on the body of the scapula extended into the spine of the scapula. And it doesn't involve the glenoid and other part of the scapula. So the treatment of this patient, based on Pires et al. 2021, this patient was treated conservatively in the absence of these criteria, which is the first one is glenoid articular. There is no glenoid articular displacement. Number two, the glenoid there is no glenoid involvement more than 25%. The scapular neck is not angulated more than 45 degrees, and there is no floating shoulder. Floating shoulder is defined as there is a dissociation of the arm with the trunk. Usually associated with mid-shaft clavicle fracture. Majority of the scapular fractures, more than 90%, are amenable to conservative treatment and present with favorable functional outcome. The expected union usually occurs between 6 to 8 weeks. Conservative management consists initially of pain management and immobilization with arm sling for 2 weeks, followed by early physical therapies. The physical therapies includes the passive assisted range of motion exercise after 2 weeks, then proceed with active assisted range of motion exercise, usually after 3 weeks, then active range of motion exercises as tolerated after 2 weeks, then the shoulder muscle strengthening after there is a sign of union, usually between 6 to 8 weeks onward. That's all. Yes, betul. Based on this Pires et al. 2021, because we can see the X-ray is only involve the body and part of spine. It doesn't involve the glenoid and the scapular neck. Scapular neck is less than 45 degrees. and there is no floating shoulder as well. Usually, if there is a scapular fracture and the clavicle fracture, we as an orthopedician, we fix each one. Usually the easiest one, which is clavicle. Okay, Dok. Thank you, Dok.
Moving on, Dato. Patient progress post-emergency lab and splenectomy by the primary team. As you can see, post-operative day 1, the patient was successfully extubated by the ICU team and was put on face mask 5 liters per minute. He was hemodynamically stable and oxygenation was maintained at 97 to 100%. He was transferred out of acute cubicle into the surgical ward/medical ward. Then commenced on nourishing fluid. This was by the OMF team. He was on PCA morphine and pain was well controlled with a pain score of 0. Chest and limb physiotherapy was initiated, incentive spirometry, 1.5 balls up. Chest X-ray was improving lung expansion. This was chest X-ray post day 1. As you can see, there was improving lung expansion compared to the presentation chest X-ray. Post-operative day 2, he was weaned out of oxygen support on day 5 of admission as well. Chest drain was removed on the 25th of August 2021, which is on day 5 of admission. He was already stepped up from nourishing to soft diet and currently at day 5 was on normal diet. He was otherwise hemodynamically stable. Chest and limb physiotherapy has been aggressive since admission and incentive spirometry was 3 balls up. Wound inspection was clean. STO was done at day 10 and the patient had no wound gapping, no discharge and no SSI was seen. The main surgical complication that we were worried of post-operatively was basically pulmonary complications, which is the most common. Mainly atelectasis, which falls at 38%, pneumonia itself at 9%, and pleural effusion 6%. Other than that, we were also worried about surgical site infection, ileus, any GI bleeding post-operatively or intra-abdominal bleeding. Chest X-ray on day 7, very good lung expansion. There was no consolidation seen. The next would be a chest X-ray review from presentation. Up to the first day, this was post-bronchoscopy. As you can see, the chest expansion was quite good. And day 7. Post-removal, 2 days after chest drain was removed. Post-operative day 14, which was the day before he was discharged on 3rd September 2021, he was hemodynamically stable, ambulating well, was able to tolerate orally. He received his Haemophilus influenza on the 1st of September 2021, and the second and third vaccines, which were meningococcal and pneumococcal vaccination on the 3rd of September. As Dato said, why we give the patient the 3 main vaccinations was because in asplenic patients, basically post-splenectomy, the spleen function is to opsonicize, but because the patient is asplenic, so it has impaired the opsonization of encapsulated organisms. Hence the reason why the 3 main basic vaccinations were given to him. This is the National Vaccination Guideline for immunocompromised patients. As you can see, the recommended one would be pneumococcal and meningococcal and also Haemophilus influenza, being whereby the booster shots for pneumococcal and meningococcal would be at 3 to 5 years, and Haemophilus influenza should be given on a yearly basis. Post-operative day 15, on 4th September 2021, the day the patient was discharged, he was very comfortable, very well, hemodynamically stable, chest and limb physiotherapy was ongoing as well. Incentive spirometry, 3 balls up. Otherwise, he was on arm spleen. Already given vaccination, we started him on prophylactic antibiotics commencement with kept amoxicillin 250 milligrams BD for 1 year. He was discharged well and we reviewed him 1 month post-discharge and also suggested him for PAS status BE 1 year and to be reviewed again. I wanted to speak a little bit on the blood parameters that we saw in this patient. Now, as you can see, the highlighted ones are of main concern. First, on presentation, we did see that the HP dropped to 7.7 and also the hematocrit of 22.7. Now, in intra-abdominal injuries, there are 3 parameters that we look for in blood investigations. First would be the HP. HP dropped here was 7.7. Second, a decrease of 30% in hematocrit, which is the hematocrit here was 22.7, actually by 30%. And also the third one would be the ALT and ALC function should raise more than 130. But over here, it was normal. Hence why I also mentioned that we as clinicians, we should recognize this kind of symptoms, be it even without a CT pancreatic traumatic protocol in this patient before that. Other than that, as you can see, the albumin levels on presentation had dropped to 20, post-op day 130, and as he was being discharged a couple of days prior to that, it went up to 31, knowing the fact that the patient was recovering pretty well. The diagnosis then was polytrauma, secondary to alleged falling tree accident, sustaining grade 3 comminuted posterior inferior pole splenic injury with the ICD coding of S36.032, moderate left hemopneumothorax with upper chest wall subcutaneous emphysema and small pneumomediastinum, which was resolved, total collapse and contused left lung, which had resolved, displaced fracture posterior third ribs with no vessel injury seen, comminuted fracture of left mandible, and comminuted fracture of the scapular body and spine. I would like to pass on to the nursing care at ICU with Sister Iju.
Assalamualaikum warahmatullahi wabarakatuh, Datuk, tuan-tuan dan puan-puan. Nursing care in ICU. Patient transferred in from OT at 2:30. Patient transferred in from OT at 2:30 hours. General condition, patient unconscious and ventilate. Patient breathing supported by ventilator as per setting. Pressure control ventilation mode. FiO2 on 0.6%, SpO2 100%. Pressure support 10, PEEP 6 rate plus. Patient on sedation, IV midazolam 8 mg per hours, IV midfentanyl 80 microgram, IV propofol run at 5 ml per hour. Patient on 6-spine Hartmann run at 125 ml per hour. Carry forward from OT, IV tranexamic acid over 8 hours, complete at 6 AM. Patient had chest tube at left side of chest. Chest tube care in ICU to keep tubing free of kink and occlusion. All connection between chest tube and drainage unit are tight and secure. Patient tube clamp in situ. The insertion site to be monitored for sign of infection. A swab should be taken from the chest drain set if there are any clinical signs of infection, such as pus, to monitor surgical emphysema to ensure chest drain remains well placed and the anchor is intact. Care of tubing, intake and tape. Maintain patency check for obstruction. Patient was extubated at 16 and 10 hours. Subsequently, patient was put on non-invasive ventilation as per setting, pressure support 8, PEEP 6 and FiO2 0.5%. Vital sign on non-invasive ventilator is 110/65, pulse rate 64, respiration rate 14 and SpO2 100%. Change to non-invasive ventilator to face mask at 8 PM with oxygen 5 liter per minute, SpO2 100%. Vital sign is 128/69, pulse rate 59, respiration rate 17 and SpO2 100%. Patient transfer out to surgical ward at 2 PM for further management. That's all in ICU, Dato'.
Just to reconfirm what I told you from the very beginning, kalau you tengok dia punya pulse rate sekarang is 59. Okay, that is the normal pulse rate. Tapi kalau you tengok to the conclusion or before that to assist your judgment. Ya, kalau tadi dia tahu pas-pas dulu, kalau pas-pas jadi supposed to be normal for all of us. But this kind of guy, where there's nothing, they go to 59cc, and they go to 80 just discussion with Richard dan doktor unit, you pegang kat pas saja. From there you will understand what the baseline of that particular setup. That will help you to come up with better diagnosis, a better response. Sebab the moment you see that, then you know there's something different. Tapi kalau you take it as a normal population of 80, that's why you just become very relaxed as if nothing happened. Okay.
Assalamualaikum dan selamat pagi yang berbahagia Datuk. Continue with nursing care at surgical ward. Okay, patient was transferred to a cubicle in surgical ward 22nd August, day 2 at 2 p.m. Patient condition, conscious and alert, on plasma oxygen 5 liter per minute, on IVD 2 pint normal strength over 24 hours in progress, chest tube intact, at left chest functioning well, and drain charting perceived done. CBD in situ with functioning well, urine output more than 30 ml per hour. Patient on PCA morphine, TED stocking on bilaterally intact, oxide wound dressing in situ. 2 tamfils, 1 pint PET cell today, HD patient 8.8 gram per deciliter. Blood transfusion given at 4 p.m. and completed at 7:30 p.m. without complication. Observation BP 106/78, pulse rate 73, respiration rate 20, temperature 37, SpO2 100% under face mask 5 liter. Chest tube drain, total 50 ml on blood, CBD 2010 ml. 33rd August, post-op day 3, condition patient alert and conscious with no any complaint, change to oxygen from 3 liter per minute taken continuously, chest tube in situ and CBD in situ with functioning well, encourage patient for deep breathing exercise and spirometry exercise. Patient on PCA morphine, taken PRN, dressing done at right mandible with Alivin AG and CMC, wound dry and clean. Force of diet today, patient taken with small amount. Continue physio done by physiotherapist in ward. Put left hand with arm sling for 6 weeks done and patient noted. Wound inspection at abdomen done today. Wound clean and dressing with saline done. Nebulizer for hourly atrovan, ventolin normal strength given. Observation, hemodynamically patient stable, SpO2 100% under nasopron, chest drain 50 ml, CBD 2,900 ml. 24th August, post-op day 4, condition patient alert and conscious with no any complaint. Encourage patient for incentive spirometry exercise. Chest tube and CBD in situ with functioning well. Continuous of diet, patient taken and tolerated. 3 IO chart done and record. Observation, patient stable. Chest drain 50 ml, CBD to 2000 ml. 25th August, post-op day 5, for upper reduction internal fixation or reef mandible today under GA, keep patient fasting for op, send patient to OT at 13-20 hours, just tube clamp while sending patient to OT. Patient back to work at 6 p.m, condition conscious and alert, nurse patient in 30-degree pro-up position. Suction PRN done. Observation, patient stable. Next, 26 August, post-op day 6. Condition patient stable, encourage oral intake, patient noted to off chest tube, done under aseptic technique. Patient comfortable, no SOB seen. SpO2 98% under nasopron oxygen. CBD of today, CS3 after off chest tube done, film seen by surgical team. Encourage intensive spirometry exercise and encourage ambulation done. Asba and eyelid wiring removed done by Lieutenant Colonel Dr. Chan. Okay, after removal of chest tube, assist patient into a comfortable position, assess patient condition, including sign and symptom of SOB, advise patient to rest at least for 1 hour or until reviewed,
Arrange a post-removal chest X-ray to be performed within 2 to 4 hours and reviewed by MO. Okay. For 27 August, for op day 7 to post-op day 8, patient ambulated well to toilet, arm sling intake at left arm, encourage intensive spirometer exercise, post-op splenectomy vaccination before discharge, IM hemophilus influenza vaccine, meningococcal and pneumococcal vaccine given. STO at abdomen done 28 August at 7:30 hours, wound clean, dressing with saline done. 31st August until 4th September, condition of patient well and hemodynamically stable, complete vaccination done for immunocompromised patient as per national vaccination guideline of Malaysia. Prophylaxis antibiotic commence with amoxicillin 250 mg BD for 1 year. Patient was discharged well on 4 September. Patient TCA, dental clinic in 1 week. TCA SOPD in 1 month to review condition and symptom. TCA orthopedic clinic in 6 weeks. Physiotherapy as outpatient.
So what are the nursing challenges yang you all face in this very particular patient?
Macam mana tadi tu?
Apa cabaran-cabaran from nursing perspective lah in managing this patient?
Untuk patient ni, alhamdulillah patient okey sepanjang duduk dekat ward. Penjagaan dia hanya untuk chest tube. Patient well lah, okey.
Tak mencabar langsung lah. Okay, but I need to ask you juga, ya, tadi you mentioned previous slide. Okay, so tu dah bagi completed mucosa, meningococcal. So have you explained to the patient on what next? Bila lagi dia kena ambil dia punya vaksin, kenapa dia kena ambil?
Kenapa kena ambil disebabkan oleh dia dah remove spleen. Salah satunya ada imun badan dia dah tak ada.
Do you explain to the patient to say?
Yes. Sebelum discharge, before discharge. Yes, Datuk. Okey, Datuk, terima kasih.
So Doctor, I'll just speak a little bit on the patient appointments, on patient's progress. So patient's appointments, the first one was at a dental clinic. Our dental clinic here was seen by Lieutenant Colonel Dr. Chan and also Great General Dr. Das. Patient was comfortable, every was patent, he was able to speak and consume normal diet. ADL independent, there was no complaints, and the next CCA was in February 2022 next year. At our SOPD clinic, we saw him on 30th September 2021. He was comfortable, ADL independent, no complaints. Our main concern, like I've mentioned before, that we were worried of post-op complications. However, noted that we checked the wound inspection again, there was no SSI seen. He was quite comfortable, the abdomen was soft, non-tender, and he was not septic looking, hence there were no signs of any infection. Prophylactic antibiotics were continued since discharge, kept amoxicillin 250 BD for 1 year and Pasmil for the next 3 months. Our next TCA to see him would be on the 8th of February 2022. Moving on, TCA at the orthopedic clinic, which was seen by Colonel Dr. Azhar on 4th October 2021. He was well, was seen 6 weeks post-trauma. On examination, minimal tenderness at the scapular region. His left shoulder noted that the abduction was at 150 degrees, flexion 150 degrees, adduction 30 degrees, and extension 30 degrees. Treatment, physiotherapy for range of motion and shoulder muscle strengthening. Next TCA will be in January 2022. At present, as of yesterday, 16 December 2021, post-trauma day 116, patient is quite well, ADL independent, and able to carry on his activities of daily living quite well. Thank you very much, Doctor.
thank you very much to all the presenters from the multiple disciplines. As a conclusion for this case, it is a challenges dealing with the polytrauma that requiring multidisciplinary approach, and all respective teams were able to perform competently to ensure a good outcome for the patient, despite we have what we call lacking in the adequate manpower as well as with the budget limitation. The good communication skills by all respective team to ensure the shared consciousness, despite each team has its own way of managing the patient. And last is about the excellent cooperation by administrators and supporting staff to manage a complex case like this. So I would like to open to the members on the floor if we have any additional input and comment about this case. Good. So with that, thank you so much. Yes, Ma'am Sophia. Thank you very much, Lieutenant Colonel Dr. Sophia. For the first question, it was highlighted in the presentation about when it was attempted for intubation in the operation theatre. That was when the displacement occurred and the bleeding started to profusely after that. And for the subsequent question about the management of the oral maxillofacial nursing care, Sister. Tak dengar. Hope it answered the question. Thank you very much. Yes, sir.
Yeah, first of all, I'll just congratulate the teams for the excellent cooperation and decision and result. One question on the medical disposition of this patient was our management. It was even test meal for 3 months.
That was the initial, yes. Betul.
And so what's the next name for it?
Let's put for BE.
Finishes this month. From here because
of risk of infections. And we were unable to reach out to him at that point, so we wanted to avoid any complications from softness for a year.
Saya nak tanya medical administration yang ini adalah post op. What is your advice to your CEO regarding the activities that you need to do to ensure the fitness level of this personnel, considering that he is a commando and he is a commando.
As this patient is evaluated to be with SPO,
not to respond him to any exercise or any operation. And in currently, we like duty at unit at the house. After 1 year, after we get 1 year, we should look at solution to the update. Can you some tips? Yeah.
Okay, right. With that, thank you so much. Before we end, I would like to invite Lieutenant General Dr. Dr. Zulkifli Manjusuf as a Ketua Pengarah untuk give a closing remark about the Grand One of today. You're more than welcome to invite Yang Bagi Datuk. Thank you.
Right, I did it from here sebab nak tengok siapa yang hadir hari ini ni. Just nak check strength juga. Okay, thank you very much for the presentation, involvement everybody. Tapi what we try to learn in every grand walk round or any walk round for that matter is that how we can improve ourselves for the sake of the patient. You know, it's sometimes very steep learning curve, and the other is sometimes that we always forget those things that so common to us. Yeah? A good example, bila kita tengok when you refer with that kind of injury, tak ada cervical collar, so these all are very basic. Okay? So that benda-benda tu kita kena keep on reminding. I know when we rush, we tend to forget a lot of things. But kalau benda itu is procedural, that should not be happening lah maksudnya. It's automatic. So saya harap untuk especially RMOs di kita punya resap pepat have to go through the training again and again. I mean with your staff. So kita tak boleh take orang kata step back and relax, tak boleh. So setiap benda-benda ni bila berlaku, then we got rather caught off guard, then thing just rushing, and banyak benda kita tak buat. Tapi kalau kita do it as a routine, then people will know what to do. So at least at your result, we can set up a proper so-called a team. So in case of trauma, siapa buat apa, then barulah orang akan ni. I know people keep on changing, but benda tu can be revised. And most importantly, that you also have to embrace all the knowledge. So jangan perasan kita tahu semua benda. Yes, some of us dah lupa, sama macam saya pun. Okay? We are not current in all issues. Dan sama bila kita dekat unit pun, kita kadang-kadang kita terlepas pandang. So benda-benda macam inilah yang saya rasa perlu untuk kita pastikan. Why? Kalau tengok, a lot of things can go wrong. A lot of things can get even worse kalau kita take it lightly. But I'm happy to say that all the team has done their job to what is expected. But there's a lot of room, orang kata room for improvement yang kita pun kena ambil maklum lah. We don't have to be so denial in this case, and we have to accept kelemahan kita And we are willing, most importantly, willing to improve for the next patient. God forbid, ya, tapi in other words, kalau ada case lepas ni, at least we know better with the understanding. And the rules still the same. Basic thing is still basic. Meaning to say that all those things yang lain hanyalah additional. Is something that a luxury that you can have. But that doesn't mean that macam tadi tengok situ salah satu isu dia budget cut, manpower. So that excuses can be there till the end of the world lah. Kan? Kalau kita want to take it as an excuse. Tapi kalau kita can maximize and optimize with what we can do or what we do with what we have, tak semestinya kata patient will succumb because of kita tak ada certain thing. Why? Because dulu-dulu benda tu tak ada pun. But people still can do well. And those are your teachers. So mean to say that they have gone through that too. Jadi anggaplah apa yang additional tu something yang kita boleh membantu. But dalam apa cara sekalipun, the outcome is still for the improvement of patient. Tak ada guna kita ada gadget macam-macam tapi patient mati. Doesn't work that way. So, but if you can do basic things proper, as simple as cervical collar, that might save patient from any nerve injury or spinal cord injury, that can be something that is very helpful. So itu yang saya nak sampaikan. But at the same time, keep abreast with the new knowledge. Okay, keep on reading. I'm also reminding myself that I should know, I should learn. Bukanlah kata saya dari administrator ni, saya tak ambil maklum, saya tak tahu what's going on. I didn't read, no. Because I have to do that. Especially being DG ni, lagilah takut kena kelentong kan. So I have to make sure that I have, I read as well. So it's applied to all of us here. Yeah? Continue doing. And not necessarily that it's not your field, that you just put it away. As at the end of the day, walaupun kata Dr. Barli psychiatrist, tapi kan tepi jalan pun kalau involved dengan accident, takkan dia nak kata sorry saya psychiatrist. Kan? Of course you need to do something. So this is where thank you, Siro, for giving us the opportunity to use this beautiful auditorium day. Okay, but most importantly, those and then members, CEOs of other hospitals or the head of the department, when you go back to your own establishment, please relay this message to each and every level of your the level of care so that they know what's going on. kita balik kita nak share dengan orang atau nak tutup, kau lebih kepada what we can learn from this very incident. Okay, so with that, I thank you very much to all of you. Sekian untuk kami budaya. Wassalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Terima kasih.
Jutaan terima kasih diucapkan kepada yang berbahagia Ketua Pengarah di atas kesudian menyampaikan ucapan dan nasihat itu tadi. Dan juga terima kasih juga diucapkan kepada yang berbahagia Datuk, pakar-pakar, pegawai perubatan serta sister di atas pembentangan kes groundwork itu tadi. Bagi memohon keberkatan dijemput Kapten Ustaz Ahmad Khairuddin Muhammad Hadir untuk memimpin bacaan doa. Dipersilakan. أعوذ بالله السميع العليم من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وأصحابه أجمعين. Ya Allah yang Tuhan kami, Tuhan yang mempunyai kebesaran, kemuliaan dan kekuasaan. Sesungguhnya di pagi yang mulia ini kami dengan rendah diri menghadap memohon taufik dan hidayah bersempena dengan Grand Round Seri 2021. Berikan kami kekuatan rohani dan jasmani bagi membincangkan segala permasalahan dan berupaya mencapai kata sepakat demi menghasilkan resolusi yang tepat. Bersempena dengan ini juga ya Allah, hindari diri kami dari rasa bosan, putus asa, tidak bersemangat dan suka membelakangkan keputusan. Sebaliknya ya Allah, isikanlah hati-hati kami dengan semangat untuk sama-sama membuka pintu, mencetuskan idea-idea yang bernas, berwawasan, berinovasi dan bertenaga demi memastikan kejayaan ini semua terlaksana. Ya Allah, restuilah perjuangan kami, tingkatkanlah iman dan takwa kami, serta tanamkanlah janji kami sifat jujur dan ikhlas dalam menjalankan tugas yang diamanahkan kepada kami. Jadikanlah kami ya Allah termasuk dalam golongan mereka yang senantiasa mematuhi segala arahan dan perintah, serta tumpukanlah perpaduan di antara kami dan sentiasa mendapat keberkahan. Allahumma ja'al jam'ana hadza jam'an marhum wa tafarraqna min ba'dihi tafarruqan maqsud. Allahumma rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Sallallahu ala sayyidina Muhammad wa ala alihi wa ashabihi ajma'in. Walhamdulillahi rabbil alamin. Amin amin ya rabbal alamin. Yang berbahagia Ketua Pengarah dan hadirin sekalian, atau cara akan beristirahat dan minum pagi. Dengan ini dijemput yang berbahagia Ketua Pengarah serta hadirin sekalian untuk beredar ke tempat yang telah disediakan. Sekian saya sudah dengan Al-Fatihah mulia. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Terima kasih.